Good morning, everyone. I'm going to present. Good morning, everyone. I'm going to present therapeutic apheresis in clinical practice, especially in the liver and kidney disease patients. We will be discussing about the ASFA guideline 2023 that came in April 2023 only. So topic we are going to discuss are definition and history, therapeutic plasma exchange, basic principles, some overview about the basic principles of the TPE. My focus will be focused on the basis on ASFA fact sheet, how it is prepared, how we have to read this fact sheet, and indication of TPE as per the ASFA guideline 2023, especially in the liver and kidney patients, and our institutional experience. So history of TPE, first plasma apheresis was started in 1914 by John Abel at Johns Hopkins University in the dogs, while first in the human it was started in 1959 by the Michel Robinson in the TTP patients. So few important definitions, like in the apheresis. By the name apheresis, simple meaning is to remove. From the blood component, if we are removing anything, that is apheresis. So separate out one or more component of the blood and remaining we just give it to patients. Like in the platelet apheresis or single donor apheresis platelet, we remove the platelet and give it back to the patient. In the plasma apheresis, we remove the plasma. So once the therapeutic word is here, so it is called therapeutic apheresis. That means the procedure is done for the therapeutic purposes. So it is for the treating a disease like TPE, therapeutic plasma exchange. We are removing the plasma, that is pathogenic plasma. There is a pathogenic substance is there. We are removing that pathogenic substance, and remaining of the we are giving it with the replacement fluid. Same is with the thrombocytophoresis for the platelet, erythrocytophoresis or red cell exchange for the RBCs, leukocytophoresis for the WBCs. Even it can be lipoprotein apheresis and many of the things. So we, the term will be the apheresis, and the thing which we are removing, that will be there. So again, plasma apheresis, as we have seen a lot of donors in the COVID plasma time. So the separate out plasma from the other component of the blood. Less than 15% of the total plasma volume is to be removed. This is the thing which we always focus in the case of donor. And the therapeutic plasma exchange, we are doing it for therapeutically. Many of the residents get confused with the low plasma low volume TPE, high volume TPE, and standard volume. So standard volume is 1 to 1.2 generally, and in the low volume TPE, it is the half of the plasma volume. Although this practice is not mentioned in anywhere in the ASFA guideline, like in the last ASFA guideline 2019 and recent 2023, only one retrospective study from the CMC Vellore says that they have done this low plasma volume. High volume TPE, it's a more than 2 plasma volume is exchanged in the single session. So a brief overview about the TPE. Whenever we are going to this, we clinician and the transfusion medicine physician see that before prescription of the TPE, what is the vascular axis of the patient, total plasma volume, number of sessions, interval between the sessions, anticoagulant, what is anticoagulant is required, type of replacement fluid, and drug dosing, which need to be adjusted, and accordingly we can give it later on if they are in the intravascular. So diagnostic workup before TPE, this is biochemical like ABG, VBG, liver, renal function, complete blood count, especially hemoglobin, hematocrit, coagulation profile of the patient, disease specific test if it is required, infection status of the patient, blood type for giving the replacement fluid, and monitoring during the TPE. Again, we need biochemical investigation, CBC, coagulation profile, and disease specific test as per required. So in this beautiful diagram, we can see this is the human. The patient connected with this machine, and we can see the blood which we are taking out from this person. This blood, once we are taking out, we mix it with the anticoagulation. The blood goes into the machine. There is a centrifugation mechanism, or it can be the membrane based, and we remove the pathogenic substance in the form of plasma, and again we give it back to the patient with the along the replacement fluid. So the basic mechanism in this is the removal of the pathogenic substance and delivery of the plasma components. So again, in this last picture, what we see, what happens in this machine. So in the machine, the blood comes in this way, and this whole blood flow in this way, in the centrifugally as well as in the gravitational. So two forces work there. One is centrifugal force that brings the blood component which is a more specific gravity. They will be outer side. We can see this red cell part is in the outer side, and the blood components which are having the less specific gravity, like in the plasma, it is on the near the center. So all the blood component after this get separated, and this we can remove the component which we want to remove. So principle of operation, it can be continuous flow of centrifugation or intermittent flow centrifugation. So generally we do continuous flow centrifugation where the extracorporeal volume is quite less and the safety of the patient increases, because in this the patient is connected with the machine and continuously there is a flow is maintained. While in the case of intermittent flow, we take the blood, we separate the plasma and give it back to the patient. So there is a more time is there, more amount of blood is required to separate out the pathogenic substance. So continuous flow centrifugation is better, and this is the machine what we are using it. But again, in the intermittent flow centrifugation, especially in the cases of donors, we use this because only we need the one axis for this. So this is the basic model by the model given by the Copenhagen scientist. But basically, whatever pathogenic substance which is present in the intravascular compartment, which is connected with the machine, that is in the connection with the extravascular compartment of the body, and there is lymphatic return, diffusion, transmembrane flow is going on. So what the Copenhagen proposed that during the process, during the procedure, generally these things are they can be like ignored because majority of the part is in this intravascular compartment, and that can be removed. So mathematical model of the TPE, that is the final concentration of the substance, depends on the initial concentration of the substance in the plasma or blood, and after that it is related with the logarithmically, and the number of the time of the total plasma volume we are exchanging, it depends. We will do, it will be keep on reducing the substance of the final concentration. So we can see with the half of the plasma volume, 61% of the fraction remain of that pathogenic substance. With the 1 plasma volume, 37% remains, and with the 2 plasma volume, it is 14% remains. But we try not to go beyond these because there is a higher chances of getting reaction in the patient. So now after this brief overview, we will go through the ASFA fact sheets. So ASFA fact sheets are been created by the ASFA 2023 writing committee, they are charged with the reviewing, updating, categorizing, indication for the evidence-based use of the therapeutic apheresis in the human disease. So they provided the guidelines. Before this, there is a ASFA categories. So ASFA categories, whatever like the indications, category 1 indication, category 2 indication, 3 and 4 indication. So in the category 1 indication, these are the first line therapy where the treatment is primary standalone treatment, like in the Guillain-Barré syndrome or in the ALF patients with the high volume plasma exchange. In the category 2 disorder which apheresis is accepted as a second line therapy, either as a standalone, but this is conjunction with the other mode of treatment, and other mode of treatments are also available. While in the case of category 3, optimal role of the apheresis therapy is not established, like they are under investigation, or enough data regarding to the RCTs are not available for that. While in the category 4, the published evidence are available, like this apheresis procedure is ineffective or harmful. So if we are doing the procedure for the category 4, IRB institutional review board approval is recommended. So grading, recommendation, strength and quality of the evidence are being looked after. So we see two things. One is strong recommendation and quality of evidence. So strong recommendation based on grade 1, and weak recommendation is grade 2. So in the high quality evidence is strong recommendation, high quality evidence 1A, strong recommendation, moderate quality evidence 1B, 1C is strong recommendation with low quality evidence. So these high quality evidence are based on the RCT without any important limitation, and jabki white in the 1B is RCT with important limitations. In the grade 1C is only observational and case series, but the response are quite good. So similar in this 2A, 2B, 2C. Well, in the implication is that in the strong recommendation with the strong recommendation can apply to the most patients. So I have made it quite simpler. Like in the strong recommendation, we can see 1, 1, 1. In the weak recommendation 2, and the if high quality evidence is there, it's with RCTs without important limitation 1A or 2A is there. In moderate quality evidence 1B and 2B, and the low quality evidence it's a 1C and 2C. So how the ASFA fact sheets are developed? So it's a systemic approach. Basically, it's been a special addition by the JCA members are been made. So it's systemic approach to fact sheet creation, revision, and category and grade assignment is the 2023 special issue. JCA special issue 1919, and they took it, and basically whatever investigation from 2019 to 2023 they incorporated all, and the editor assigned 10 fact sheet per committee members, and the first draft was made. After that was reviewed, and the second draft was made, and it was reviewed by the members, and third draft was made, and with the third draft was a personal in-person meeting was there, and after that it was the final version was made, and this is the version which we read now. So fact sheet basically in the fact sheet we can see there is a B, C, the particular location of the disease, the diagnosis of the disease, incidence, incidence, indication, number of patient on which we are having the data, RCT, CT, case series, and are available or not. Description of the disease, current management, rationale for the therapeutic plasma exchange, technical notes, what the replacement fluid is required, what are the key factors, and then references. So we can see A to U are the things. So we can, I've taken one fact sheet for the acute liver failure, where we can see its the incidence is less than 10 by per lakh per year. Indication is for the acute liver failure, and it can be in the two way, TPE in high volume and TPE is with standard volume. So TPE with the high volume is comes under the category 1 with the good strong recommendation, and category 3 with the moderate quality evidence are there. Again, there is a acute fatty liver of the pregnancy that the indication is the category 3, and the reported patients are more than 300. So basically, we can see TP with the high volume 183 in the Larsen study, and the TP this include our institutional study as well. So we contributed in this. There is a this description of the ALF is there, a brief description of the in the ALF. And again, there is a current management and treatment. All the available modes of the treatments are there. In the rationale of the treatment, they have included the studies which have done, and in which we can see the Larsen study and one study from our department and our hepatology department on the 40 patients. So, and the replacement fluid, what we can use is plasma albumin is there, and duration and discontinuation. So number, it depends on the 12-hour or at least every next day it's the frequency is there. So what's new in this 9th edition of the ASFA? There is previously they were only incorporating till the 2019 they were incorporating RCTs, CT, CS, and case reports. While in this edition they have also considered systemic reviews, evidence-based approaches, and the general layout was similar to the 4th edition of this. It recently 91 fact sheet and 166 graded of the categorized indications are in this, and 7 new fact sheets are included, 8 changes in the category of the existing indication, and 9 new indication on the existing fact sheets. So we can see incorporate as a new factors Alzheimer disease, autoimmune dysautonomia, idiopathic inflammatory myopathies, immune checkpoints inhibitors, paraneoplastic autoimmune retinopathies, transplantation of the intestine, which is of our importance, and vaccine-induced immune thrombotic thrombocytopenia has been new factors, and incorporated these things, mechanical hemolysis incorporated into the acute toxin, venoms and poison, methylhemoglobinemia incorporated into the acute toxin, venoms and poisoning, and bone marrow necrosis, are incorporated into the sickle cell disease, which were the previously factors. So insufficient evidence, these are also in the under the review at the time. They have not added this in this, but they were also considered, and they might be. We can see into the after the 4 years in the next we can see hyperbilirubinemia and kidney failure with the bile cast nephropathy are available there. So what is the changes in the categories? So 2 indications were upgraded, especially in the erythropoietic porphyria and the liver disease. Previously it was in the category 3. Now it is in the category 2. Inflammatory bowel disease with the ulcerative colitis, category 3-2. It is shifted to the category 2. And 4 indications are downgraded. Age-related macular degeneration from 2 to 3.
Ashish, I was expecting more of liver related. This topic.
Ma'am, maximum is liver related only, but these.
So you have left out Wilson's because I think that is
Ma'am,
one
I'm
very
going there
important.
also.
Okay.
So age-related macular degeneration is a dry high risk is from category 2 to 3. Babesiosis in the severe from category 2 to 3. Hyperleukocytosis again downgraded. Red blood cell aluminization, and in the vasculitis, if it is ankylosed, they are also been downgraded. So therapeutic apheresis procedures which are relevant to our institute based on the ASFA categories: acute liver failure, TPE, high volume TPE, and category 1, and if it is the standard volume, it's category 3 with the moderate evidence. Sepsis with multi-organ failure. Previously it was recommendation was in the 2B, and now it's evidence are more evidence are available. In the liver transplant patient, TPE, immunoadsorption, and DFPP.
Sepsis is chronic liver disease?
Yes, sir.
Sepsis with multi-organ failure?
Sepsis with the multi-organ failure. It can be CLD patient or ALF patients, but we can take everything.
Okay.
Yes, sir. Desensitization, ABO incompatible living donor, desensitization ABO disease donor, that comes under the category 3, and antibody mediated rejection in category 3. So while Wilson disease, it's a TP, we are doing TP with the high volume in our institute, and there is a removal of the copper in the patients, and still it's in category 3, but there is a weak recommendations are there. So in the erythropoietic protoporphyria, TP RBCX can be done, and to reduce the plasma porphyrin levels, that comes under category 2. Pruritus due to hepatobiliary disease, we get it few of time. The treatment resistant to the anti-allergics, and in the vasculitis patient with the hepatitis B, polyarteritis nodosa. In the renal disease patient, therapeutic apheresis procedure based on the ASFA category, renal transplant patients, ABO compatible and ABO incompatible, TPE, and generally these are in the category 1. In this addition, disease donor category has been removed, only live donor are there. While in the antibody mediated rejection, in the liver transplant patient, it was category 3. In this renal patients it is category 1. Anti-glomerular basement disease, and these are like many of the diseases of the renal are included. Like same in the focal segmental glomerulosclerosis and IgA nephropathy. So our institutional experience in the therapeutic plasma exchange, I've taken from 2019 to 2022, 8 patients undergone the therapeutic plasma exchange. Out of that, 809 were the adult patient and 89 patients were the pediatric patients. 2,527 procedures were done. So major condition of the disease, from which we have done TP in the adults, is the ACLF patients with different etiologies, chronic liver diseases, DILI patients, ALF according to their numbers. In the ALF, if it is the high volume, it's the category 1, and if it is the standard volume, it's the category 3. acute viral illnesses, LDLT, graft dysfunctions, majority of in the category 3, Wilson diseases, 8 patients in the adults. While in the pediatric age group, ALF was the most important diagnosis we have done, and that was followed by the Wilson disease, ACLF, DILI, CLD patients, and hemophagocytosis and acute liver hepatitis, and also in the LDLT graft dysfunction patients. So these are the distribution, and we can see majority of ACLF, CLD, DLE, and LF patients. So a few studies from our institute which are published. Standard volume plasma exchange improves the outcome in the patient with the acute liver failure, a randomized control trial. So this is also the study included in the ASFA 2023, and this study was done on the 40 patient with the 1-to-1 randomization, and what they found as standard volume plasma exchange was associated with a higher 21-day transplant-free survival. And again, additionally, they see the anti-inflammatory cytokines along with the decrease in the endotoxin and DAMPs was seen. And simultaneously, there was a reduction in the cerebral edema. Well, a study from the Department of Pediatric Hepatology, in the 37 patients they have finally included in that the Wilson disease, they have found that 90 days transplant survival was quite higher. That was like 47.3% in the high volume plasma exchange group in compared to the 16.6% in the SMT group. So it was the first study where the efficacy, we can see the survival here in this high volume plasma exchange group, while that was lesser survival in the SMT group. So study was compared to the SMT in the setting of von Willebrand disease. The therapeutic plasma exchange improves the system. One study again that from our department, therapeutic plasma exchange improves the systemic inflammation and survival in acute and chronic liver patients, a propensity score measure study from AARC. So what they found that it was large extent by the systemic inflammatory response syndrome, and additionally the patient who had development of the AKI was less. So role of one study I have taken from the CMC Vellore, I have told you, so that there is a retrospective study by the Santosh et al. From the CMC Vellore. They have done it on the 40 patients, out of that 21 patients from the Plex group and 29 patients from the SMT group. And what they found, they found that better survival over 1 year in the Plex group compared to the SMT group. And additionally, renal function in the 10 patients in the Plex group was, out of that 6 patients, the renal function was improved. So, my summary and tag is TP procedure performed by the trained personnel are safe and effective therapeutic approach for the patient suffering from the disease listed in the ASFA guidelines. Useful technique in the prevention of the complication in the setting of acute liver failure. Correlation of the coagulopathy is possible without volume overload and with the protection of the renal function. However, the TP is not a replacement for the definitive therapy, and for the liver failure, final treatment is liver transplant. Thank you.